So today's speaker, Dr. Yang Zhan, who is a second-year advanced cardiovascular imaging fellow here at Houston Methodist. Yang came to us by way of University of Calgary, where he did his medical degree, and the McGill University in Montreal, where he did his training in both internal medicine and cardiology. And unfortunately, we're going to lose Yang as he's going to be moving back to Canada shortly after he finishes his training. Yang has completed 2 years of training that really encompasses cardiovascular MRI, as well as advanced echocardiography and cardiac CT. And early on in his training, Yang took a significant interest in valvular heart disease and really focusing on the right side and the tricuspid valve. And in fact, he had he was selected as one of the finalist presenters at the ACC Young Investigator Award competition for one of the research projects that he worked on, which I think he's going to highlight today. And he's really going to give us an update on tricuspid regurgitation, functional tricuspid regurgitation, what it is, the current state of the art in the year 2019. So welcome, Yang.
Thank you for that kind introduction. Set this up here. All righty. Okay, it's a pleasure to be here today to presenting to you all. I have no disclosures. So what I'm going to talk about in the next 45 minutes or so is about functional tricuspid regurgitation. And there's been an increasing interest in this topic. If you just search kind of Pubmed here, you can see over the last 5 years or so, there's been an accelerated pace in the number of publications, mainly looking at the prognosis, the management, and also the quantitation of functional TR. And I will try to explain, well, how did we get here, and what is the current status of functional TR, and then what is it going to look like in terms of the future. So I'm going to cover this in 5 kind of mini topics. The first is why functional tricuspid regurgitation is important, and what is the current surgical management of that. And then we're going to really delve into the underlying mechanism of what causes functional tricuspid regurgitation, quantitation, or maybe newer forms of quantitation of functional TR, and then future transcatheter therapies. So patients with tricuspid regurgitation are very heterogeneous. Here's a typical patient who gets an echocardiogram with a chief complaint of dyspnea. As you can see here on the left, this is the RV inflow view, and you will have to use a little bit of your imagination, but I will tell you that there's decreased RV systolic function, and there is tethering of the anterior and septal leaflets on the left. And on the right, if you were to catch it in the first couple of playthroughs, is a parasternal short axis view at the level of the mitral valve with the RV systolic function once again suppressed, and also signs of RV systolic pressure overload indicated by the flattening of the septum in systole. So now we're looking at the apical 4-chamber views, and ideally what I wanted to show here was that there was an enlarged right atrium and right ventricle with dilated tricuspid annulus. And of note, the left atrium and ventricle were of normal size. And on the right was an image of a color Doppler level at this level, which showed a significant flow convergence at the mitral valve level, suggesting significant tricuspid regurgitation. Then a continuous wave Doppler through the tricuspid valve really shows, on the left here, really shows a dense triangular early peaking jet. And on the right, a pulse wave Doppler of the hepatic veins shows some very prominent systolic flow reversal. So taking all these images into account, most would grade the degree of tricuspid regurgitation here as severe functional tricuspid regurgitation, and likely with the normal left ventricular left atrial size was not due to left-sided heart disease. But so then the next question is, how important really is functional tricuspid regurgitation? And that really we can break down into 2 thoughts here. First is, how common is it? And the second is it significant by itself? So is functional TR independently associated with worse clinical outcomes? Or really is it the kind of underlying disease that governs the overall prognosis? So we can look from Olmsted County data here, and really it shows that the degree of moderate or greater tricuspid regurgitation increases with age, and always follows around 1/3 to 1/4 of that of the combined prevalence of aortic stenosis, mitral stenosis, aortic regurgitation, and mitral regurgitation. And therefore, if you look at patients greater than 75, roughly 4% or 1 in 25 community individuals will have moderate or greater tricuspid regurgitation. When we look specifically at the people with severe tricuspid regurgitation, it is estimated conservatively that roughly 1.6 million Americans have this condition. And in one study, and multiple studies have followed after, they looked at severe tricuspid regurgitation and found that over 90% of severe tricuspid regurgitation is functional. And in 10% of that, there were no other factors that they could identify as a cause of this severe tricuspid regurgitation. So really the answer to how common functional TR is that it is quite common, and the majority of severe TR is actually functional. So then the next question is, how is it associated with worse clinical outcomes, and is it independently associated? And I think this is an important question because really this has been debated on and off in the last 50 years or so. If we look kind of one of the earliest studies, taking you all the way back to 1967, there was a report by Dr. Nina Braunwald who looked at 28 patients who underwent mitral valve replacement with mitral regurgitation or mitral stenosis. And they also had associated severe tricuspid regurgitation. At that time, there were the typical characteristics of severe TR and also the typical optimal medical treatment, which included sodium restriction, digoxin, diuretics, and rest in these people. Of these 28 patients, 3 of them underwent tricuspid valve replacement, and 1 of them died during the hospital, but she followed the other 24 that did not have any tricuspid valve intervention. And on the right here, you can see that all of these individuals had elevated RA mean pressures, and that after surgery, the RA mean pressure reduced. When we looked at the RV systolic pressure or pulmonary artery systolic pressure, once again, it was elevated around 75, and then after surgery, it went down to around 40. And then of the 24 patients that didn't have any tricuspid valve intervention, she followed these patients up for 4 years and found they had significant clinical improvement symptomatology, and about 2/3 were able to resume a sodium-full diet and enjoy life. So from that, she deemed that, well, tricuspid regurgitation is reversible after left-sided surgery, and hence it is not that much of a concern. However, further reports or later reports showed that that wasn't always the case, and in a good proportion of individuals, it was to remain and sometimes even get worse after left-sided heart surgery. So future studies focused on, well, what about severe TR and its prognostic value in kind of the whole cohort? The first one of these looked at 4,100 patients from a VA hospital in San Francisco. And this was tricuspid regurgitation graded with echocardiography, and more specifically with a parameter known as jet area over right atrial area. These patients were followed for 4 years. And in this cohort, it included patients with primary and secondary TR. But you can see that the majority of these patients had secondary or functional TR with over 98%. And although in this cohort, if you can see on the right side table here, mainly composed of no TR groups and mild tricuspid regurgitation groups, there were still around 17% or 1 in 6 individuals with moderate or greater TR. And what they really found was that TR severity was independently associated with decreased survival. And then they tried to look at different groups. So they looked at groups where they had pulmonary hypertension, and they found that this relation still applied, and groups with normal pulmonary pressures. Similarly, in groups with heart failure with reduced ejection fraction, severe TR was significant, or TR was prognostically significant, and also in heart failure with preserved ejection fraction. So this kind of first established the independent prognostic utility of functional tricuspid regurgitation, and future studies looked at different subtypes of functional TR. So one of the studies here looked at isolated tricuspid regurgitation, which we now believe may be more and more so due to atrial fibrillation. And here they looked at the quantitative tricuspid regurgitation with echocardiography, using a parameter known as effective regurgitation orifice area, and they found that it was independently associated with death, cardiovascular death, and recurrent hospitalizations. In this study with heart failure, 3 measurements of tricuspid regurgitation by echo were found to be able to stratify patients in those that were more likely to survive and those that were more likely to die. So it really looks like all the data is pointing to one direction, that TR is prognostically significant. But that's not actually the case, because not all studies showed that TR was independent of predictor or association with mortality. So in this study, again, with also heart failure with reduced ejection fraction individuals, they took 576 patients, and apart from the usual clinical and imaging risk factors, they also assessed heart failure biomarkers. And they found that although on univariate analysis, tricuspid regurgitation was associated with increased mortality, that on multivariate, it was really the serum sodium, functional class, and also NT-proBNP that were suggestive, that were prognostic of death, and not TR by itself. When looking from a cohort similar to Dr. Braunwald's 50-something years ago, these are patients who had prior left-sided heart surgery and then had severe TR or tricuspid regurgitation following that. And in this study, they did a comprehensive right ventricular assessment using echocardiography. And once again, on univariate analysis, we can see that TR is associated with decreased survival, but on multivariate, it was really the RV systolic function. So why is there this conflicting degree of outcome data? And I think there's really three main reasons for this. So the first is that there were a bunch of heterogeneous subjects. So some studies looked at the whole population, some looked at isolated TR, some looked at HFrEF, and those after prior left-sided valve surgery. That there are different echocardiographic quantification of tricuspid regurgitation that I alluded to on the previous slides. And also, I think more importantly, there's a variability in RV function assessment. And we know that really there's a complex interplay between tricuspid regurgitation, RV size, and RV function, and also right atrial size, and that severe tricuspid regurgitation can cause RV dilation and decreased function if left for long enough. But I also will show you later that RV morphology changes can by itself cause severe TR. So I'm going to try to explain how this was all utilized in the prior prognostic studies. So here are the studies that I mentioned, and in the middle column, you can see the parameters for RV size they adjusted for, then the parameters for RV function they adjusted for, or they gathered, and then on the right side, really the size and function parameters that they actually adjusted for in their papers. And you can see really only a subset of RV parameters were adjusted for, likely due to factors such as collinearity. However, most did adjust for RV function, and they did so with TAPSE and fractional area change, which are echocardiographic parameters. So then the question is, are there any alternative ways to assess RV function? And I think there are, and that's really with cardiac MRI. There's a couple of advantages using cardiac MRI to look at RV function, and really that it has an unobstructed field of view, that there's excellent myocardial to blood cavity contrast, so when we delineate end diastolic and end systolic volumes, it's very easy to see the borders between the blood and myocardium. And importantly, there's no geometric assumptions. And RV ejection fraction is both highly accurate and reproducible, both in vitro, with CAS, and in vivo. So the next question is to ask, well, how do parameters on echo for RV function match to parameters on cardiac MRI for RV function? So this is a meta-analysis released last year looking at 17 studies with 1,280 patients. And we can see here that the correlation is modest, and that for fractional area change, really the correlation is 0.56, and TAPSE, the correlation is 0.4. So in a condition where tricuspid regurgitation has a lot of dependence on RV size and function, and that echocardiography may not correlate that well with RV, with MRI-derived RV function or calculated RV function, it would be ideal to incorporate cardiac MRI RV function assessment in the analysis for TR. And that's what we were able to do recently, where we looked at 547 patients who underwent cardiac MRI with reported cardiac MRI-derived values of tricuspid regurgitation. We looked at both tricuspid regurgitant volume and tricuspid regurgitant fraction. And aside from the clinical and biochemical variables, we also adjusted for other variables, including biventricular volumes and function by cardiac MRI. And what we found is really that regurgitant fraction was a better predictor of mortality in our cohort. So on the left here, we see a Kaplan-Meier curve with survival stratified into our three risk groups, really with regurgitant fraction under 30%, 30 to 49% and greater than equal to 50%. And on the right is a multivariate Cox proportional hazard model. And we can really see that as tricuspid regurgitation fraction increases, there's an increasing risk of death. With the highest risk group, with a tricuspid regurgitation fraction group of greater or equal than 50%, having 2.5 times the mortality as individuals with a regurgitation fraction of less than 30%. And you can also see that RV ejection fraction is also a strong predictor of death in this cohort. So really, the take-home points from this first part is that TR severity is independently associated with mortality, and now this is studies spanning multiple imaging modalities, which is 2, and also with robust adjustment for RV size and function. So now that I've shown you that functional TR is associated with a worse outcome, I want to take some time to explore the surgical or historical surgical management of functional TR. And when we look in the last 10 years, we can see that the number of isolated tricuspid valve surgeries is relatively small. Here you can see the surgical volume. In red is tricuspid valve replacements, and in blue is tricuspid valve repairs. And we can see that although they are increasing, that the number was estimated around 5,500 across the whole United States. And surgical mortality is high in this cohort, with reported being 9 to 10% for in-hospital mortality alone. And this mortality is higher than surgery on any other valve. Part of this reason may be because patients present only when they're kind of too far gone, when they have signs of RV dysfunction and congestive heart failure and RV overload. And part of the reason for that is that really when you look at the guidelines for indications for surgery for functional TR, you can see that, well, if you have functional TR, you should go for repair or replacement, sometimes even if there's only moderate or mild tricuspid regurgitation. But that's really at the time of left-sided heart surgery. So what if you're doing it not at the left-sided heart surgery? And that we don't really know. There's really no guidelines for this. And really because there's a kind of a lack of data in this area, and the 2017 valve updates don't actually reflect this either. So here is a paper that was just released this month looking at surgical treatment of functional TR and how that relates to mortality. So this was at the Massachusetts General Hospital, and they followed basically 3,000 patients who had echocardiograms with severe TR without any left-sided heart disease. Once again, you can see very few patients in this 15-year follow-up had isolated tricuspid valve surgery, 5%, and the majority were repairs rather than replacements, much like the prior graph that I showed. We can see that the LV systolic function was preserved, and the RV systolic pressure, there was some degree of pulmonary hypertension, but unfortunately this paper, they didn't mention exactly the RV systolic function or parameters of RV systolic function. But what they did find is that when you compare medical and surgical management in this cohort after propensity matching, there was really no difference in mortality. And actually surgery kind of trended in the wrong direction. And when you look at the Kaplan-Meier curves, you can see that these are virtually overlapping between the medical and surgical arm. And part of the reason why this is the case is really that surgical treatment of tricuspid valve functional TR is only really modestly successful. So in this retrospective cohort from the Cleveland Clinic of 2,300 patients, these patients underwent tricuspid valve replacement but also had concomitant left-sided valve surgery. So that's why there were so many of them. So on the left here, we can see the type of repair or replacement they had, and the majority of these patients had annular repairs, but some had commissural techniques as well. On the right here, we can see the grade of TR post-op. And we can really see at 3 months, or almost a couple months post-op, that roughly 1 in 3 patients had moderate or severe TR after tricuspid valve repair or replacement. And then at 5 years, this increased to almost half the amount of people. And therefore, we can see that in this surgical management of functional TR, that there are really limited or no guidelines for this, and that isolated tricuspid valve surgeries are rarely performed. And really that is because of relatively high mortality and the possibility of significant residual TR even after surgical treatment. So I've shown you some bleak news, that TR is associated with poor outcome and that surgery may be high risk, and also does not seem to reduce mortality. So are there any alternatives that can save us from this dark night full of terrors? And there may be. and that may be with these transcatheter tricuspid valve interventions. But there's a lot that are currently being investigated and currently being developed. So why are there so many different devices, and what kind of mechanisms are they targeting? And I believe to really kind of understand this, we really should delve into kind of the mechanism and etiology of functional tricuspid regurgitation. So functional TR is divided into 4 main etiologies. The majority of functional TR is due to left valvular and LV dysfunction, which you see here around 50%. And the other causes include pulmonary hypertension, primary RV dysfunction from RV ischemia and cardiomyopathy, and a good 9 to 10% have idiopathic or isolated TR that don't have any other notable risk factors. And this proportion of patients tend to be older, female, and a high proportion of them have atrial fibrillation. And it is increasingly suggested that this population, the reason they have severe idiopathic TR is really due to atrial fibrillation in itself. So the 2 main mechanisms that are responsible for functional TR are tricuspid annular dilation and leaflet tenting. So the first, with tricuspid annular dilation, this is caused by right atrial dilation, and also morphologically, we can see that the basal right ventricle is also dilated. With leaflet tenting, this results from either RV geometry changes or papillary muscle, which cause papillary muscle displacement in part due to RV dilation. So really, to understand how these mechanisms cause functional TR, we have to review a little bit about the anatomy. So here we can see that the tricuspid valve is the largest of all the valves at around 7 to 9 centimeters squared. On the left here, we can see the tricuspid annulus in blue. And there's really kind of 2 functional components. You have one component which sits at the level of the septum, and that really is relatively immobile with RV remodeling and tricuspid regurgitation. And the other part, which is kind of the D that wraps around the anterior and posterior leaflets and the lateral wall, that dilates as the tricuspid valve dilates, and that's shown in the arrows. On the right side, we can see there are usually 3 leaflets of the tricuspid valve. The anterior leaflet is usually the largest, the posterior leaflet is the shortest circumferentially, but the septal leaflet is the smallest radially, and also the least mobile, and also the one that is most likely to be tethered. In the normal valve, the leaflets overlap by around 5 to 10 millimeters, which is also known as the coaptation reserve. When we look now at the subtricuspid apparatus, we should note that in 80% of the patients, there are 3 papillary muscles. That is the anterior pap muscle, the posterior pap muscle, and the septal pap muscle. While in 20% of the patients, the septal pap muscle is missing, and multiple septal chordae join the septum itself. On the right side here, we can see that these pap muscles, which are designated in red, and their associated leaflets. It is important to note that the pap muscles are kind of situated in between the leaflets, and they supply, and chordae from the 2 adjoining leaflets go to that pap muscle. For instance, in this case here, we can see that let me just grab this laser pointer. We can see that the septal pap muscle will take chordae from the anterior and septal leaflets, the posterior pap muscle from the posterior and septal leaflets, and the anterior pap muscle from the anterior and posterior leaflets. So how does tricuspid annular dilation and leaflet tenting cause significant TR? And I think this was demonstrated very elegantly in an in vitro study where they took 16 porcine explanted valves and also their 3 papillary muscles. And they hooked it up to a flow device to simulate normal flow conditions of the heart. On the annulus, they attached a flexible ring to simulate annular dilation. And in their experiments, they displaced the papillary muscles in different configurations at about 1 centimeters in length to simulate LV or RV dilation and papillary muscle displacement. And really what they found is that when they started with a valve area of 6 centimeters squared and progressively increased the annulus size by itself to an area of 12 centimeters squared, that leaflet malcoaptation occurred when the annulus was only dilated by 40%. And when we compare this to the left side, the mitral valve requires 75% of annular dilation before mitral regurgitation occurs. So the tricuspid valve apparatus has much less give in that respect. Additionally, with isolated annular dilation, the anterior leaflet had basically the greatest reduction of coaptation because it was pulled as the RV wall was distended laterally. and I'll show that later as well. When we looked specifically at papillary muscle displacement, we can look at models of RV dilation, which here there's apical and lateral movement of the anterior pap muscle, or LV dilation, in which the septum kind of bulges to the right, and then we really have different configurations for the posterior pap muscle and the septal pap muscle for displacement. And what we found, and what they found, I should say, is that when we look at either compared to controls, that if there is anterior pap muscle displacement or septal pap muscle displacement, both these can cause an increase in the degree of regurgitation fraction. And interestingly also that the septal leaflet had on the right here, a decrease in the percent change of residual leaflet length. And that's really the coaptation distance, which meant that it was the one with the greatest degree of tenting. Not surprisingly, when they combined both annular dilation and papillary muscle displacement, this created the greatest degree of tricuspid regurgitation. So I think this is great and all, but how does this happen, or does this happen with patients themselves? So I want to show you this study where they looked at 280 patients with severe tricuspid regurgitation, and they divide them into two cohorts, those with idiopathic causes and those with due to pulmonary hypertension. And this could be primary pulmonary hypertension or pulmonary hypertension due to left-sided heart disease. So all of these patients were matched in terms of LV ejection fraction, and they all had preserved ejection fraction, and they were matched also for age, sex, and effective regurgitation orifice area. In these two groups, we can see that the effective regurgitation orifice area was about 45 millimeters squared. So this would deem them as severe tricuspid regurgitation by today's standards. And what they found when they compared these two groups is that patients, so here is a bar graph showing that 3 sets of patients. So in the black here, I just want to orient you, are the controls, so patients with no tricuspid regurgitation. And the white are patients with idiopathic or functional tricuspid regurgitation, and in the middle. And on the right are patients with pulmonary hypertension, subset of functional tricuspid regurgitation. And what they found is that patients with idiopathic functional tricuspid regurgitation really had larger annular sizes compared to those with pulmonary hypertension functional TR. That pulmonary hypertension functional TR had greater tenting height compared to those with idiopathic functional TR. When we look at the RV cavity itself, idiopathic functional TR had larger basal diameters. Both idiopathic and pulmonary hypertension functional TR had larger mid-cavity diameters, but pulmonary hypertension functional TR had a greater RV length, or the RV distance was greater. Now I just want to look also in patients with reduced ejection fraction. So in this cohort, they looked at 384 patients with functional TR that was at least mild, and they found that all of these patients had LV dysfunction without a primary cause of tricuspid valve or right ventricular disease. And what they did here was they calculated both the tricuspid annulus size, RA size, RV size, but also calculated a ratio called the RV spherical index, where they really looked at the right ventricular end systolic area, as seen here traced in green, divided by the RV length. And what they found was that tricuspid regurgitation severity was only affected by RA area, RV spherical index, and tricuspid valve tethering height. And that tricuspid valve annular diameter was really not associated with TR severity. And therefore, if we take all these together, we can see really that there's 2 mechanisms of tricuspid regurgitation. There's one where there's annular dilation, and in this case, the anterior leaflet is pulled over laterally and causes malcoaptation. And the second, there is papillary muscle displacement, in which case, because of RV geometry changes, the septal leaflet is tethered, and that's what causes tricuspid regurgitation. When we try to match that to the etiologies of functional TR, we can see that annular dilation is really caused by or associated with atrial fibrillation, while papillary muscle displacement is seen in patients with functional TR from left-sided heart disease, pulmonary hypertension, and probably also RV cardiomyopathy. So here's a case of atrial fibrillation, and you can see really that the annulus is dilated, the RA and LA in this case are severely enlarged, but the RV parameters are maintained, and that the annulus and the leaflets itself are not tented. So we look here that once again, RV dimensions are preserved, and the annular and basal RV is enlarged, but the mid RV is of normal size, and the RV is in normal length. Contrast this to a functional TR due to left-sided heart disease, and we can see that in this case, that there's a significant amount of leaflet tenting, that the mid part of the RV diameter is increased, but the annulus is roughly intact in size, and also the RV length is increased in size. However, not when one of these mechanisms of severe functional TR occur, they can kind of drive the other mechanism as well. So if there's any kind of abnormal coaptation resulting in TR, there can be progressive both annular dilation and leaflet tenting, and this goes further and further, and then you have a condition where there is both annular dilation and leaflet tenting present. And these really are the patients that are at the highest risk, surgical risk, and kind of have the greatest symptoms when they present. So really, annular dilation and leaflet tenting are the two mechanisms that can independently result in severe functional TR. These mechanisms are caused by the underlying etiology of TR, and they have different presentations and different mechanisms. But both mechanisms are present in severe end-stage TR. So I'm going to quickly talk about how this can, or these mechanisms can be, or could be incorporated into future quantification of tricuspid regurgitation. So originally, tricuspid regurgitation was quantified using right ventriculography. And you can see here during systole that different degrees of tricuspid regurgitation show differing opacification of the right atrium and right ventricle. But now, tricuspid regurgitation is mainly quantified using echocardiography. And really that assesses two components here. The first is regurgitation quantitation, which looks at regurgitation volume, and that usually uses different parameters on echo. Regurgitation fraction, which can be used on echo but hasn't been so far, and other markers or surrogate markers of regurgitation that can be quantitated, vena contracta, effective regurgitation orifice area, and jet area. And the second component is to see the effects of severe tricuspid regurgitation, both on the right atrium, the right ventricle, pulmonary pressures, and also on preload in terms of IVC and hepatic vein reversal. So the main recommendations to assess tricuspid regurgitation using echocardiography are described in this guideline that was published around 2 years ago. And many of these parameters here you can see are either specific for mild tricuspid regurgitation or severe tricuspid regurgitation and validated against angiography grade right ventriculography or thermal dilution. However, in the cases of uncertainty, the guidelines recommend that quantitative measures are suggested. And really these quantitation parameters are the ones that we used or authors have used to prognosticate patients as having independent prognostic risk for functional TR. And although there are limitations with using these parameters themselves, and that you can see that the cutoffs are different based on the different patient population, this is kind of by and far the most accurate way we have to assess functional TR at this time. However, the echocardiographic evaluation of TR currently does not take into account the mechanism of what causes TR. So what could be suggested is that instead of taking just the qualitative criteria and semi-quantitative criteria and the quantitative criteria, but to integrate it in a way such that we have quantitative parameters of TR, and then we try to assess the two mechanisms. Is there annular dilation? How is the leaflet coaptation? What effects it has on the ventricle? And if we have the clinical note, what kind of clinical effects on the patient? And we kind of do this already when we look at patients with TR in the echo lab. However, this would be a way to kind of structure the mindset on how to approach this valvular problem. So I'm going to spend the last couple of bit of my talk describing about transcatheter tricuspid valve interventions. So we're back to this slide, in which case there are multiple devices to treat multiple causes of TR. And ultimately, the reason to assess each of the mechanistic causes of TR quantitatively and using imaging is really to better select the right patient for the right intervention. So we can see that there are devices that really target tricuspid annular dilation, and this is through a ring annuloplasty. There are devices that target leaflet tethering, that's through suture annuloplasty. And when tricuspid regurgitation is kind of severe and end stage, there are devices that either help the leaflets coapt or kind of bypass the tricuspid valve apparatus in and of themselves. So there are multiple small early feasibility trials that I won't go into today because they're going to future lead to bigger trials and RCTs. But I think the greatest experience with transcatheter tricuspid valve intervention is with this tri-valve registry, which really in their last publication, they had 312 patients with high-risk tricuspid regurgitation. And really, this is an international registry between North America and Europe. And here you can see that there's different devices in terms of leaflet devices with the MitraClip and the Pascal. You can see annular devices with the CardioBand, the TriCinch, and the TriAlign, and then replacement devices with through the Great Venous System and transcatheter tricuspid valve therapy. By and large, the majority of patients that receive tricuspid repair or transcatheter tricuspid repair is through the MitraClip and leaflet devices. So the patients that do receive this intervention are ones with a very high surgical risk. So their Euro score on average is around 9%, and majority of them had received it due to functional TR. They had signs of right heart failure with ascites, peripheral edema, and worsening NYHA functional class. And importantly, their LV ejection fraction was only mildly depressed, and they had severe tricuspid regurgitation by echocardiographic standards. And actually, the degree of tricuspid regurgitation is now thought, in this case, to be even more than severe, so what people would say as massive tricuspid regurgitation. When they looked at this breakdown, so this is a breakdown of their results based on the type of device. What's important to note is really that most of these had roughly a 70% procedural success, and here they designated procedural success as post-op TR of less than 2+. And importantly, none of them had any procedural mortality, and the 30-day mortality in this registry was 3.6%. And if you compare this to the national surgical cohort, it's around 9%, so a large difference there. When we look at different parameters, so here is looking at TR at baseline and TR at 30 days, we can see that the majority of patients, roughly 60%, had a reduction of TR to 2+ or less, denoting procedural success. After intervention, there was a non-significant but reduction in RV function as assessed by echocardiography. And once again, this is kind of what's expected if we look parallel with the mitral literature. And patients felt better. So compared to baseline, at 30 days, around 60% of patients had NYHA class 2 or less, and this at 6 months maintained to over half of patients had NYHA 2 or better. And specifically, on the bottom part, on bottom graph here, bar graph here, you can see that it makes sense that patients that did not have any tricuspid regurgitation reduction did not have any decrease in NYHA functional status. And then finally, they looked at mortality, and although this is a registry, they found that procedural success was associated with a better mortality compared to procedural failure. So looking at the predictors of survival in this registry group, they found that, well, what I mentioned before, that procedural success was highly significant, and also pulmonary pressures were highly significant. And looking at then what are the causes of procedural success, well, the main thing that was against procedural success was coaptation depth, and this really meant the degree of tenting of the tricuspid valve leaflets. And this has kind of been found also in the surgical literature, in that the patients that had the greatest degree of tricuspid leaflet tenting tended to do the worst and have recurrent tricuspid regurgitation after intervention. And we're kind of seeing that this is kind of translating to the transcatheter world. So in summary, functional tricuspid regurgitation is independently associated with mortality and has been undertreated historically due to perceived lack of treatment benefit and high surgical mortality. So the mechanism of tricuspid regurgitation include annular dilation and leaflet tenting. And although these individually can cause severe TR, really both are present with severe end-stage TR. The main imaging modality should still be echocardiography, but maybe we need an integrative approach to kind of involve prognostic right heart parameters and the mechanism of TR to really guide patients for the right therapies. And that transcatheter techniques are promising in treating these patients with severe TR, but larger scale studies are needed. So I'd like to thank everyone for their attention, thank all the staff and fellows and support staff that I've worked with in the last 2 years, and special thanks to Dr. Shah for mentoring me. Thank you.
Great. So, congratulations, Yang. That was really outstanding and phenomenal presentation. And I want to really commend you for kind of taking on this field, hopefully as a long runway for your career. Because I think there's still a lot that we need to learn about the right heart and the tricuspid valve. And I think you did a great job with a very nice, coherent presentation. So I want to open it up now to any questions from the audience for Dr. Zhan. We've got Dr. Quinones back there.
Yeah, I want to add to Dr. Shah's comment. That was really well done. I mean, you could have been an invited guest from another institution with the quality of presentation you gave. In the mitral world, we're beginning to get some insights from doing this 3D modeling, working with U of H, trying to look at stresses in the valve. Is that also something that we should start doing in the tricuspid? Would that also give us more insight in terms of mechanisms and also success of different type of treatments? Because we already have that sort of thing going, with the collaboration with U of H and everything. Is that something that we should also try to embark for tricuspid valve?
Thank you for the comment and the question, Dr. Quinones. So I think that's a good point. We can, looking at the strain and kind of modeling of force on the tricuspid valve can give us additional insights on tricuspid valve pathology. The majority of these patients have intrinsic, leaflet tethering from right ventricular effects or using mainly right ventricular strain and annular dilation. And it's actually unclear and probably unknown what is the strain on the leaflet themselves in secondary TR. So that's something that would be interesting to see and may give us additional insight into how best to treat these patients.
Yeah, I'd also like to echo the excellent quality of your presentation. That was very impressive. Couple of things. One is, I think that the emphasis on MRI is going to be very important going forward. A lot of this literature you quoted really is in the category of junk in as much as what we see in the operating room compared with what we're told pre-op on regular transthoracic echo is not very predictive. As far as surgical repair is concerned, isolated tricuspid valve surgery in de novo patients has a relatively low risk, actually. Isolated tricuspid repair in the presence of previous cardiac surgery has a very high risk. And I didn't really see that point brought out in your data. So you can have an isolated tricuspid repair in someone who's had a previous aortic or mitral valve and now comes back in heart failure late in their course. And those people tend to have a high mortality, both for technical reasons and because of their cardiac status. And they, I would say, as a category, are the ones that suffer most from failure to stabilize preoperatively. And in our own experience here, we brought the mortality down from about 14% to the 3 to 5% range just by getting these people in and keeping them in the hospital for 10 days or 2 weeks and getting them out of heart failure and measuring the right ventricle with MRI and using that RV volume, 150 to 200 mil per whatever, using that as a parameter to try to get them stable enough to go through the surgery. As far as the surgery itself is concerned, obviously we have a choice between repair or replacement. It's fairly well established in the surgical literature that when we do repairs, the ideal repair is going to be a circumferential annuloplasty ring-based repair. appears to have the greatest long-term reliability. The bicuspidization, where the tricuspid valve is plicated out, is still useful in sick people where you've done a couple of other valves. It's a 5-minute surgery to do that, and so that's a useful backup thing, but it definitely has a lower long-term success. The other lesson I learned from Dr. Kleinman is that mild to moderate TR, as I think your data showed really, in a lot of those studies, mild to moderate TR was not very predictive of any adverse events. And even a repair, if you have mild to moderate TR, MR after a mitral valve repair, that's a big problem. They're going to be back soon in big trouble. If you have mild to moderate TR, actually from a clinical point of view, the cardiology feedback I get is these people become very easy to manage with minimal amount of medication and do quite well in the long term. But I think there's a lot of work to be done. Your point to be made about the interaction between tethering and dilatation is a very important one too. That's a very important point. So I thought that was a great presentation, very comprehensive and very excellent. And I'd love you to get, I've got a database with a couple of hundred tricuspid repairs. I'd love you to get someone to come and write a paper on and publish it.
Thank you for the comment, Dr. Lowry. What you mentioned is completely correct. So the data that I showed was tricuspid regurgitation, tricuspid valve repair and replacement in the whole kind of experience, not just isolated and not just kind of first without prior cardiac surgery. So the risk would be lower if there was with no redo intervention. Looking specifically at the interventional components, you mentioned the majority is really due to kind of an annuloplasty or closing of the annulus or reducing the annular size. And I wonder, in the groups that have a significant degree of tricuspid leaflet tethering and RV dilation, if that could be one of the reasons why there's, in some patients, there's significant TR even after this tricuspid valve repair. Because even though the annulus may shrink in size, the leaflets may still be tethered, kind of thing.
Well, if you look at the surgical literature, there have been multiple different types of repairs, and I would say in general, a lot of the tricuspid repairs that have done have been poor quality, technically poorly executed surgeries. I think that's a big part of the explanation. And there's at least half a dozen different little nips, tucks, stitches, strings that people use. But I think the data from Europe and from the other big centers suggest that just a flexible annuloplasty ring gives a more durable repair. And then just one other thing you didn't mention, carcinoid disease, which we see a steady little trickle of. And typically they always have to be replaced because the leaflet destruction is shriveled up.
That's a good point.
Yeah, so Yang, great job. The decision on when to operate is very a tough decision. I think there's a lot of, we don't know about these patients. The ones that are obvious that they need surgery often are too late. They have ascites and oftentimes cirrhosis. So you had some great imaging data. I didn't see, there's not a lot of clinical data in terms of kidney function, liver function as surrogates, or hemodynamic data, which we use a lot, but to help guide decisions, although there's not a ton of data. Just wanted your comments on incorporating hemodynamics, clinical data into the picture, and you had a lot of imaging data. If you could pick 2 or 3 of the most important things, I think it looks like regurgitant fraction in your data was one of the most important. But if you can just kind of highlight a few of the key factors in deciding on who's a good operable candidate.
So I think one is, like you were mentioning, regurgitant fraction or some kind of quantitation of tricuspid regurgitation severity. That's kind of like the first kind of step to see, well, is the TR severe or not, and how severe is it? And the second one is really to look at what's effect it has on the right heart and congestion. So these include some degree or assessment of RV function, whether by MRI or by echo, some degree of biochemical in terms of like liver dysfunction and kidney dysfunction. And actually, although I didn't present it here, there was a recent, I think, article on transcatheter intervention of the tricuspid valve and its resultant effects on patients with liver and kidney improvement. And they showed that in the vast majority of them, they did have improved liver and kidney function associated with their improved symptoms as well. So, and there have been some other studies that looked at, that did look at registry data to see, or single center data to see in patients that did get isolated tricuspid valve surgery, was there MRI RV cutoff in terms of volume? And there was. It just can't come to me at this point, but there was a cutoff they used that showed that after the RV gets to a certain size, that mortality kind of increased.
Yeah, great talk. I'm going to echo everybody's statements on how all the comprehensive data that you had. Little piggybacking on Barry's comments, RV is extremely pliable when we see these patients, especially post-transplant, post-VAD. And I've had cases where you have severe TR and you volume optimize them and everything gets better. And just like in an echo report, if it's severe MR means nothing if their blood pressure is 180/100, that's afterload sensitive. For TR, I think it's preload and afterload. And how do you, is there data, one, that predicts independent, like if you have severe TR, despite optimization with an RA pressure of 10, to me that's more valvular pathology. So is there data to suggest that your RA pressure or your PVR can be used in optimizing? Because we learned from the COAPT trial, right? COAPT and MitraClip, the MitraFR suggested if you don't optimize heart failure enough, the benefit might not be that good enough. What are your thoughts on that when you're doing the imaging part and reporting the hemodynamics to then put it into the interpretation?
So great question. So the short answer is I'm not sure because I haven't looked at that. But there is some, I know there's some data that looks at looking at leaflet tethering, and that leaflet tethering itself, first of all, I should say that I agree that tricuspid regurgitation is highly preload dependent, and that severe TR can become mild TR with adequate diuresis and volume kind of reduction or preload reduction. Now, there's some data that shows that leaflet tethering, if it's there initially, will still kind of remain. And really that's because of RV dilation and RV lengthening. And those things won't necessarily get better after preload reduction. Whereas annular dilation may actually start to shrink if the preload has addressed. So there's maybe some signals there to see which ones may improve after aggressive diuresis, which patients may not.
Yeah, so again, terrific, well done. Couple questions. So I wish the transcatheter companies, hope they go on to the DeBakey site and look at your talk, because I think what's missing is a recognition of the mechanisms as you discussed, the annulus dilation, the primary, and the other one is the tethering, because most devices approach one or the other. And short of a transcatheter replacement, there isn't a device that really addresses both. So they're really not going to be one solution for everybody because of these important mechanisms. Which one do you think, which device that's coming, do you think, based on your sort of anatomic investigation, has the most potential?
That's a hard question to answer. Like you mentioned, Dr. Little, it really depends on what is the main mechanism of severe TR and how far gone or how end stage is this severe TR? Are there both mechanisms present? How dilated is that annulus? How big is that RV? How tethered are those leaflets? And so ones with, with small amount of annular dilation, I think all of those annular devices may work. There's good early feasibility data, but I don't know how this translates to further trials. For mild tethering, the current mitral clips or edge-to-edge repairs work quite well, and I know you see that from the from doing the intra-op interventions. But when it's too far gone, right now, as you may know, they're really looking at kind of the only one that kind of interacts with the leaflets and annulus is the Forma device, which kind of just sits in the tricuspid valve, and that really doesn't improve the annulus or leaflet physiology at all. It just creates a kind of a spacer device where the leaflets kind of rest on. So it's possible that when things get too far gone, maybe it's kind of a semi-palliative approach, and that that there is no real one device fits all in functional TR kind of thing.
So just my follow-up was, so yes, we've done the clipping, 1,000 cases or so with, with variable success depending on the right anatomy. We're about to start, we just got our approval letter for the Tri-Cinch study, which is an annular device. So we'll be starting that Methodist experience very soon. The follow-up question is, in your guidelines review, you talked about severe TR. Currently, the bucket is equal to or greater than a bunch of cutoffs. And in the literature and the discussion is really introducing these notions of massive and torrential TR as real things. I mean, these are categories that should be acknowledged, and that, in theory, moving somebody from torrential to severe with a catheter or other intervention may have benefit. That is a groundswell that's growing, and this recognition that it is a continuum of risk within TR, and you can have massive volumes beyond what you see on the left side. Is the MRI field going to start reporting massive and torrential TR?
I think it's premature right now. Maybe in the future is my wash kind of response. Thank you.
Nadia?
Yes. Hi, Yang. Excellent presentation. In patients with idiopathic tricuspid regurgitation, younger to middle-aged patients with normal hemodynamics at rest, good functional capacity, moderate to severe tricuspid regurgitation, is there a utility to fixing it earlier and improving their long-term outcomes and RV remodeling and preventing complications?
So is this, thanks for the question. So is this idiopathic tricuspid regurgitation, is it related to atrial fibrillation at all?
Nothing.
or-
It was done in your MRI lab, the man that I was asking for.
Okay.
He has nothing.
Okay, so I guess the first thing would be maybe because maybe some of these patients may have subacute or transient atrial fibrillation or paroxysmal atrial
possible.
fibrillation.
Yes.
So really to kind of look to see if there is an underlying AF. And the second thing is to make sure, it's really idiopathic, that there's no primary leaflet abnormality, and that really it's kind of that model of atrial dilation, annular dilation, basal RV dilation, but the RV function and RV size is normal. And then after that, it's kind of, there's no guidelines for this, right? So, and really, we know that intervention risk it may not be very high, but it is a risk in itself. And it would depend on what is the trajectory of this tricuspid regurgitation. And I don't think we know specifically right now with these other forms, subsets of tricuspid regurgitation, what is the trajectory. And really, after knowing that, we would be able to recommend then what are the interventions in that case.
Great. Well, thank you. Outstanding again, Yang. Thank you very much. So was this your laptop?
Yes.
Okay. So Ivan, yours.